Good evening, everybody, and welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Dr. Turab Said from Scotland, United Kingdom. Dr. Said is a consultant trauma and orthopedic surgeon in Scotland, working in the Forth Valley Royal Hospital with private practice in Scotland at BMI King's Park Hospital and at Manchester and the Harley Street, the Harley Health Village in London. Before moving to Scotland, he was consultant trauma and orthopedics at the Royal Free London Hospital. Dr. Said has been a principal investigator for 2 prospective randomized controlled trials and has published and presented at several leading societies, including SICOT, Royal Society of Medicine, Charing Cross, and Imperial College Orthopedic courses. Dr. Said has done masters in sports and exercise medicine, has been the team doctor for England football team C and other clubs in England. Dr. Said is also fellowship trained in trauma, lower limb arthroplasty, and foot and ankle surgery. So today, it's my great honor to introduce you to Dr. Turab Said from Scotland, United Kingdom. Over to you, Turab.
Lovely. Thank you ever so much, Gopalan. That's brilliant. As we know, the topic today is Morton's neuroma or Morton syndrome. And I'll put this thing in the beginning in blue, which is Civinini, which was the first guy who described it. But unfortunately, it depends whoever is more popular. The name takes after that. So the name is after Morton's, who even described about 30 years later than when it was originally described, but the name caught on from him. Okay, so what is the Morton's neuroma? Morton's neuroma is most commonly found in the third interdigital space. So for that reason, some people don't call it Morton's neuroma. The current trend is that it should be called as intermetatarsal neuralgia or intermetatarsal neural syndrome. And one thing important is that in the third interspace, the medial and the lateral plantar nerves, they send a branch each. And because of that reason, the third digital plantar nerve, which is purely sensory, tends to become thicker in volume compared to the other. As you can see it over here, that this nerve is thicker in volume compared to the other one because there's a combination or amalgamation of 2 different nerves. And if we look at it, it's underneath the intermetatarsal or deep transverse metatarsal ligament, which are over here. I'm not sure whether you guys can see my thing or not, but this is the intermetatarsal ligament, and then the plantar nerves are over here underneath. And it's in the third interspace, which is between the third and the fourth toe. Now, the reason I put this picture over here is that the symptoms are primarily on the plantar aspect. And if you can see, the people used to do surgery in old days on the plantar side. And over here, somebody has done surgery in the 2 web spaces, both in the third and the second one. And if you look over here, they look slightly more collided, but this is an old picture. In the current days, people tend to do from the dorsal incision and not at the plantar incision. Most of the surgeons would do dorsal incision, though there is one RCT where they've looked at both dorsal and plantar things, and they had more complications slightly in the plantar surgery group. So it's not only just the neuroma of the third web space. Generally, everybody, any neuroma you find in the web space or any neuroma you find in the intermetatarsal space, either underneath the transverse metatarsal ligament or beyond the transverse metatarsal ligament, as one study showed that when somebody is in the push-off phase or when somebody is in the mid-stance phase, the neuroma is beyond the transverse intermetatarsal ligament, is called as Morton's neuroma. But if we want to be really pedantic, then the neuroma in the first web space should be called as Hütter neuroma. And the second interspace between the second and the third toe should be called as Hauser neuroma. And in the fourth interspace, Iselin neuroma. These neuromas are less common. The most common one is in the second interspace. And why do they have these names? Because whoever first described them, they had the privilege to give the condition their name. Now, what is a Morton's neuroma? Although the name suggests that it's a neuroma, so we would think that it's a tumor. And sometimes we'll say, look, this is a benign tumor. But truly, if we look at it and look at histology, it's not really a tumor of the nerve. It's actually the fibrosis of the epineuron and the perineuron. And it's associated with collagen being deposited around the nerve itself in the kind of swirls or whirls, which is called as Raynaud bodies. And the thing is that this collagenization or increased collagenization of the nerve is not only in the nerve, it's also found in the blood vessels, i.e. the digital arteries. And we don't really understand why exactly this process happened, either as a result of repetitive trauma, either as a result of acute insult or trauma, or whether it's associated with other conditions to which I'll come in a little while, which other conditions it is. So let's go on to the next slide, which would show you in much more detail that how the swirls around it is the perineural and epineural fibrosis, and this is more magnified compared to this picture where you could just barely see it, but on this picture, it becomes really clear that how much fibrosis is present over there. Now, sometimes the Morton's neuroma could be associated with the tarsal tunnel syndrome, and there was a study where they found out that those people who had the ongoing symptoms after removal of the Morton's neuroma, and when they considered them whether they had a recurrence, they did the nerve conduction studies, and they found that about 54% of people had symptoms suggestive of tarsal tunnel syndrome. So it's very important that when you're examining one for Morton's neuroma, you should also look for tarsal tunnel syndrome. And in those people, the pain would be higher up. The pain could be in the calcaneum. They could have numbness going on to the outer side of the foot. And one should do a Tinel sign at the tarsal tunnel to see whether that produces any pain or not. And now this would bring on to the thing where some people suggest that Morton's neuroma could be because there's reduced interspace between the metatarsal heads, and they are much more closer together, and that's why they end up having their neuroma. And if you look in this particular picture, the neuroma is sometimes found before the intermetatarsal ligament over here. You can see it's thickened up, and it's sometimes beyond it. And when you cut it, then you increase that space between the metatarsal head, which is just like when you have a carpal tunnel syndrome, you go and release the transverse carpal ligament, it increases the space for the nerve. You don't go and do anything to the nerve. And we'll discuss this concept later on, that why we go and take a nerve out in Morton's neuroma, and we are happy about it. But when there's a problem with the carpal tunnel, we just go and release the nerve. Somebody might tell me that, look, carpal tunnel is a motor nerve and this is purely sensory nerve, so it doesn't make a difference, but we should talk about evidence, and I'll refer to evidence later on. So now this is another very important cadaveric study, which was done in 1993 by Levitsky et al., where they found that, yes, people can have communication between the medial and the lateral plantar nerve going into the third interspace, but about 73, they had exactly about 73.4% of the cadavers did not have a communicating branch, i.e. there was an absence of communicating branch. So this then refutes the theory that, look, because there are two branches joining and they're becoming thicker, that's why they're getting the Morton's neuroma. So now, what does the patient complain of? So patient says that, look, they have found a pebble in their shoe, they take their shoe off, they shake it, look inside, they can't find a pebble. Sometimes they feel like they're walking on a millet, or they get a feeling that they're walking, their socks have wrinkled up, especially if they've got a mercerized cotton socks. They take the socks off or take the shoe off, and they see that, look, the cotton does not have any wrinkles in it. Sometimes they also find that when they've been driving with their foot in slight dorsiflexion, it gives them the pain. And they need to remove the shoes. Sometimes they have to massage it, like in carpal tunnel, people wake up and they shake their hands. Similarly, they have to massage their foot and the pain gets better. It's a sharp nerve type pain. You have to ask them, does it feel like a shooting pain, electrical pain? Or people would say that, yes, it feels like that. And they could be tingling or the numbness in the toes. If this is the third interspace, you have to presume my hand is a foot, then there would be numbness in the interspace, but the outer sides of both toes would be fine. And this tends to happen during the later stages of the Morton's neuroma. And then at times they can come and tell you that, look, I can feel something clicking, or I can feel a lump in my foot, in the forefoot area. I can move it. I feel it moving up and down. And this is an interesting fact. Locke in 1983 described that people can present with pain in their foot when they're having orgasm or defecation if they have got a Morton's neuroma. An interesting fact, isn't it? So what symptoms? The symptoms are very important, because when we read the book, when I initially became consultant, I used to think that what the book says is absolutely right. But then I started listening to patients, and now sometimes I find the patients come and tell you the symptoms which are not written in the book. So it's very important that you must listen to the patient and then try to judge that whether that would fit with a particular issue or problem or not. So majority of people have pain while they're walking, and I did not used to think that the cramping sensation would be our cause of the motor neuroma, because I used to tell patients several years ago that, look, this is a purely sensory nerve, so don't tell me you're getting cramps in your feet. But as with time went by and more patients said that, and then I researched the literature, then it says that yes, up to 30% of people can have cramping sensation in their foot purely from a sensory nerve rather than from a mixed nerve or a motor nerve. So predisposing conditions. So anything which is wrong with your foot theoretically can predispose you to pes planus, because the feet are really flat. So the forces are going through in it. You do not have the medial longitudinal arch, or pes cavus, because the arch is too high. There would be increased forces resulting in metatarsalgia. Or somebody has got equinus deformity, that their Achilles tendon or the gastrocnemius is tight, and they've got the tight cord. So you would look at people doing the silver skull test, and if that's you cannot reproduce the dorsal wrinkling, which is a new sign that I have. I'm writing it up, that if you are able to get wrinkling on the dorsum of the foot, then your silver skull test is negative. But if you do not get the wrinkle, then it's positive, meaning that your gastroc is really tight. The traditional way has been that you fully extend the knee, and then you try to look, while you're doing it, try to look it from the side, whether you have been able to get the plantigrade of your foot or not, with the knee flexed and knee extended. And then ill-fitting shoes like tight toe box, or people wearing high heels that the girls would like to do, that can lead to having motor neuroma. And then abnormal proximity of the metatarsal heads. If we consider that this is a tunnel, and the walls of the tunnel are made by two metatarsal bones, and there's a transverse or deep intermetatarsal ligament underneath it, and there is cars going through the tunnel. If we make the tunnel narrower, the truck which could go easily before through that road now won't be able to do, and you only be able to drive a mini or a small car. So if somebody has got abnormal proximity of the metatarsal head, that can lead to a tightening of the fibroosseous tunnel, and then they can have symptoms. And then forefoot deformities like hallux valgus and hamartosis. And hamartosis are interesting. Not only hamartosis can cause Morton's neuroma, but the Morton's neuroma surgery can result in hamartosis, and we'll come to it in a little while. So it's important that rather than saying, oh, yes, I think you've got Morton's neuroma, to look at the other causes, like whether you've got the MTPJ degeneration, MTPJ inflammation or synovitis, you've got a plantar pad or capsule degeneration with a tear in the plantar plate, you've got a Freiberg's disease of the second metatarsal, which may be leading to inflammation and pain, or whether you've got a referred pain coming on from your back, or you've got metatarsal stress fractures, or you've got some other peripheral neuropathy or a metabolic peripheral neuropathy. And sometimes you can have other tumors like a schwannoma or a lipoma, which may be reducing that thing and causing the symptoms, or it could be something very similar like tarsal tunnel syndrome, which is present up to 54% of the patients when they are re-examined after they have got recurrence of the symptoms following surgery for motor neuroma, and they undergo EMGs and they have tarsal tunnel syndrome, or it could be a simple tumor of the metatarsal bone. So this is just a picture to show you about somebody who had a schwannoma. So they had an MRI scan done, and this was removed. And the main thing message to take from here is that Morton's neuroma, if you have an MRI scan done, appears low intensity signal on both T1 and T2. So T1 is normally used to look at the anatomy, and T2 is to look at the pathology. And T2 is like, if you guys know H2O and T2O, that's a good mnemonic to remember, that H2O is water and T2 wherever there is water, that would glow up or would show a high signal, and schwannoma normally appears hyper intense on T2. And the reason that Morton's neuroma appear low intensity on both T1 and T2 is because it's full of fibrous tissue, and that does not glow up because fibrous tissue is thickened and it has got very minimal water content in it. So coming up to epidemiology, when do you find it? Most people, they present, they're in their 40s, 50s and 60s, and they would commonly ask you, oh, doctor, why do I get it? Is this something I was born with it? Probably, certainly they were not born with it. If they were born with it, then they should have the symptom much earlier in their teen years or in the adolescent years. So this is probably more likely a degenerative thing, because the histopathology shows that there is increasing whorls of collagen which get deposited over time. It's more common in women. Some studies show up to 80% common in women, and that's certainly true in my clinical practice. I see a lot more women and very few men, but men do get it. And so then the question is that, is it related to footwear? We think it's related to footwear. Normally, some people come, they're wearing tight toe box shoes, while the other people who come to me, they're wearing sensible broad toe box shoes, and they do not get Morton's neuroma. Men normally have broad toe box shoes if you look at all the shoes for men, while the women, their shoes tend to be curving and have a narrow toe box at the front. Whether that's vanity or fashion, hard to say, without being disrespectful to any female colleagues who are listening to this. It's most common in the third web space, as we said, but it's also found in the second web space. Now, physical examination. Probably these days we tend to rely less on physical examination, but call me old-fashioned and old school. I still try to touch my patients, and I'll still try to examine them. And so we normally do not find any swelling, but if you do examination, you would be able to find, and it's very reassuring for the patient when you say, look, I have felt the click and I think you would have a Morton's neuroma. Let's get an ultrasound scan or MRI scan then done to confirm it. So when the patient then comes back, you've already developed a rapport with the patient, because patient knows that, look, this person knows what I was going through without even looking at the pictures. He has examined me, he told me the diagnosis, and then the investigation was done just to reconfirm. And it's very important in treating patients, because medicine or surgery is a bit of an art and bit of a science as well. And if we can develop a good trust with our patients, then that helps in designing successful treatment algorithm and plans. And if things do not go as per plan, as we'll allude to it later on, like steroid injection or the conservative treatment, then the patient knows that, look, this doctor has got my best interest at his heart and he's being honest and upfront. So going back to the examination again, sorry about slight digression, altered sensation can be present, but it's a later sign. And the muddler click, we talk about it a lot, where you have to squeeze the forefoot and then you pressurize the space and you feel it or hear it. A patient can have pain. And now there's a newer muddler click, which is called as ultrasonographic dynamic muddler click, where the ultrasonologist, while doing the test, does the same maneuver and is able to reproduce the click and can see the neuroma moving up and down as well. So this is telling you that you're trying to do it. So this is the first picture. So this is not the true picture that how to do it, but I tend to do it that not only I palpate, I try to squeeze, if this is the foot, between the metatarsal head and see if I can squeeze something. Just start off doing by this and then squeeze the forefoot and then do the muddler click, which is this one, that way you have to squeeze the forefoot and then you're doing it. So this happens because it tends to be, you're pushing the nerve down underneath the intermetatarsal ligament, and because there's some surrounding inflammation and there's some movement with the thick fibrous tissue, it causes that pain and produces that lump, produces that click. And now this is the thing, that if you ask them to stand on the tiptoes, which is the demi-point position as the ballet dancers they stand, that would stress the commendator nerve and they would get their pain. And similarly, when somebody's feet are like this, when they're driving, that's probably the reason that they feel the symptoms of neuroma when they are not weight bearing. Normally they are weight bearing, but while driving, they're not weight bearing and they're still getting symptoms from Morton's neuroma. So it's primarily a clinical diagnosis, but you can't just operate on somebody or do an injection blindly, although people do blind injection, but these days we are doing more and more ultrasound guided injection. I would start off any patient which comes to my clinic, call me because I'm a foot and ankle consultant, that I do the weight bearing AP, lateral and oblique views of the relevant foot to exclude metatarsal stress fractures. Sometimes we cannot exclude them because if there's an early bone marrow edema syndrome, then you have to do an MRI scan to look for any MTPJ degeneration, to look for any abnormality of the metatarsal head and whether they are far too close in one space compared to the other. Another idea is that you can give purely a local anesthetic injection in the clinic blind in the space at the point of maximum tenderness. And if that gets rid of the pain, then you can do a quality diagnostic injection. But normally I send my patients for ultrasound, and ultrasound in preference to MRI scan because it can give us that dynamic mudless click as well. But if we are not sure on the ultrasound scan, or I suspect that there could be a plantar plate tear or something else, then MRI is much more preferable. But ultrasound is much more widely available and can be done. If you've got an ultrasound machine yourself, you can do it in the office rather than sending them to a radiologist. And it's normally done in the coronal plane. So this is, if we look at it, if we look at the second and the third metatarsal head, you can see the heads are really close together, while the third and the fourth and fifth, there's a reasonable joint space. And this is also called as second space syndrome with the presence of the Morton's neuroma because of the increased pressure there. The toes start getting diverted, or some people call it as Star Trek sign as well. So I'm not sure whether you guys can see it. There's a significant gap between the second and third toes, and it's called a second space syndrome. And this is, as I was saying, that on Morton's neuroma, sometimes we do get the MRI scan, and this shows that, look, it doesn't matter what sequence, whether it's T1 or T2, it's a low intensity signal. So the treatment options is, yes, we are surgeons, but not everything needs surgery. So we should start off with the wider shoes, especially with the females. A good idea is to make them stand on a piece of paper, draw around it, then put the shoe onto it and say, look, if your shoe doesn't fit your foot, you're trying to fit your foot into the shoe, you should get a shoe which fits your foot. And probably that does have a contributory effect, because if we are doing the squeezing, then that's what we're doing in the mudless click, which is causing pain. So if they've got a tighter shoes and you chain them to wider, then their symptoms can settle down. The other one is to give them metatarsal dome if it's one space, or you can give them a metatarsal bar. People have done injections, and injections vary. Most commonly used injection is corticosteroid in practice. But if you read the literature, you would tend to think that, oh, 66% of patients, according to literature, gets alcohol injections, while only 23% of patients get corticosteroid injection, and about 6% of patients get hyaluronic acid injection. But it depends, because there's a publication bias, where the publications are more regarding the alcohol, and we inject corticosteroid every single day, but we do not publish it. So if you just read the literature, it gives you a skewed view that, look, we should be doing probably alcohol injections, or everybody else is doing alcohol injection, though that's not the case in normal practice. Now, alcohol has got a temporizing effect. It can give you good benefit for up to 3 years. And some people also give vitamin B12 injection. And some people think that vitamin B12, because it has got effect in peripheral neuropathy, that's why it works, while other people think that it works because the preservative for vitamin B12 injections is alcohol, and it's that alcohol which is working. And while we're at the subject of alcohol, alcohol is normally used as a sclerosant agent, and it's used as a 4% injection, and the alcohol has to be repeated after 2 to 3 days. On average, people need somewhere between 4 injections over a period of 10 to 2 weeks, while corticosteroid is if any of you have got any military background, this is fire and forget technology. You inject it and then you forget. You don't have to see the patient on a few days basis. You give them and you probably bring them back to clinic in 2 to 3 months time. So one can do 2 to 3 injections over a course of 3 to 6 months for corticosteroid. Important thing is that up to 80% people can have relief from the corticosteroid injection. Those which have got a neuroma size more than 6.7 millimeter, this is the latest hot off the press. It came in foot and ankle surgery, I think a couple of months ago. 6.7 millimeter, they do not tend to respond very well to steroid injection, and they have a high chance of going to surgery, but it's still certainly worth doing a corticosteroid injection as the first line, as there's up to a good chance that people may not have any further need for anything. And I do tell them that, look, about 80% chances that you would settle down with 2 steroid injections. And if you don't settle down, then we have to go down the surgical route. And important thing to remember is that I tend to do corticosteroid injection under ultrasound guidance, because then it's near the neuroma. But if you do it blindly, which is done, one should be aware that you do not go too down to the plantar side, although you have to go to the plantar side, but not too deep down that you damage the plantar fat pad or damage the collateral ligaments or lead to plantar plate tear. Because if you do, then you have to have surgery or you have to manage those conditions then. And if the corticosteroid injections have not worked, then the surgery, again, is not 100% success. There's nothing 100%, I would think. So a good 85 to 90% success, because some people will still continue to have some symptoms even after surgery, and they may require future surgery or revenge surgery, which is always difficult because of this scar tissue formation. And surgery itself has got various different ways of doing it. So we'll discuss that in a little while. So this is just an algorithm. So if somebody comes to you, you examine them, you look at the symptoms, then you see that whether they've got any findings on the examination, you do the Mudler click and the other maneuvers, and then you do the x-rays or the ultrasound and MRI scan, and you exclude the other conditions, treat them non-operatively, then do the surgical compression. And if they still have symptoms after surgery, then consider other diagnoses like tarsal tunnel syndrome, or consider that whether they have got chronic pain syndrome and whether they need to be referred to chronic pain team, or whether doing something else would be beneficial or not. So here's a simple trick how one can make a metatarsal pad. I thought that this would be helpful for this particular presentation, because if you're in an outpatient clinic, and like in our hospital, the ortho test is in a different hospital, so we have to refer the patients to go there. You can at least do something for the patient there and then in the clinic by this simple technique while they're waiting their appointment with the ortho test to get a metatarsal dome. And these are the different kind of pads which can be put on to help with this symptoms, including some of these go on the insole, they can go on top, or they can go underneath to offload the metatarsal, so that that particular interspace metatarsal had, they are not going onto the floor when you're walking and you put the metatarsal dome proximal to it, so it's offloaded. And then similarly, there's some of these things can be put on the outside, like over here on this shoe. This has been put over here so that we can offload that and they do not have symptoms. Oh, and another way is that if somebody has got these curly toes and something else, then you can use these kind of pads, because when you straighten the toes, there would be less stretch on the nerves and their symptoms would improve. And this is another simple trick to do that by using some simple Velcro tape if you have available, or you can do the similar thing with the Carnesio tape as well. Now, as I said earlier on, that surgery is not without risks, and this is looking at the third MTPJ, which is being stressed before and after. And you can see that when we stress the third interspace, the space opens up. It's very subtle, but it is there. And then you can easily excise the neuroma. And this is the laminar spreader which we have put in here. So now this is the one which I was saying earlier on, that one can have fat pad atrophy, one can even have FDB rupture after steroid injection, and you can also have collateral damage, collateral ligaments of the MTPJ, which can result in MTPJ instability. So it's important that when you're doing the injections with steroid, you're careful, and that's the reason that I try to do it with the ultrasound guidance, because then you know where the injection is exactly going rather than trying to put it in a broad area. So surgery. Surgery can lead to either it could be recurrent neuroma surgery, which is obviously would be difficult because of previous scar tissue, but surgery can also consist of just neurolysis, like carpal tunnel. You go and decompress the nerve and you neurolyze it. Or there was a study where they showed that they did the decompression with the dorsal transposition of the nerve. What they do is they cut the intermetatarsal ligament, put a longitudinal 6 of proline into the wall of the nerve, and you would wonder that nerve is already not behaving well, and you're trying to put another suture in it, and then you put the suture into the periosteum of the adjacent metatarsal head, and you lift it off the plantar aspect because you've already cut the intermetatarsal ligament. But I normally don't do it, but you would think that whether that would put some stretching on the nerve and can lead to some neuropyrexia of the nerve or not. But obviously, because this is for training purposes, it's important that you're aware of this option. And then one can do a transection of the deep intermetatarsal ligament, and another option is to do a laser ablation. And some people do Weil's osteotomy, which shortens the metatarsal head. Thus, if you shorten the metatarsal head, there's less pressure being put in from the side. Or Messera osteotomy, which is a double Weil's kind of osteotomy. And if somebody has got equinus deformity, you do the gastroc recession. And again, the concept is that, like in diabetics, when there's a gastroc tightening, they have metatarsalgia and they get pressures, ulcers in the forefoot. Similarly, there's increased pressure going through because of the equinus gait. And that's why probably neuroma is developing. And if you release the gastrocnemius muscle, then you'd be able to get rid of it. So we're going to quickly go through the surgery. I always tend to mark my patients so that you know exactly what you're going to do, where you're going to make your incision, and how long would it be, and transverse lines across it so that you can suture the skin back. So I roughly make about 3 to 4 centimeter incision. I say that be really generous with the incision, but don't go mad. But don't make a tiny incision, because if you make a tiny incision, you have to put a laminar spreader there, and you won't be able to do things. And you need to be able to do things. You can see things, because I try to. I'm very particular about not damaging the digital arteries, which can be damaged in quite a significant percentage of patients if you're doing the excision of the Morton's neuroma. So I tend to be generous with my incision, but don't go mad. So then put the retractor over there, and then put the laminar spreader so that you can open it up. And some people want to do laminar spreader under the X-ray so that they can be sure that they're not overdoing it. But I have been doing it over years, so I'm quite comfortable, so I don't use X-rays. But you need to be really careful, because if you go really mad, and the key is to do it gently, do it few clicks, then give it some time so that there's stress relaxation of the bone and soft tissue, and then do another click or so, and then do that, rather than go mad like a typical orthopedic ox. And because it has been reported that people have caused metatarsal fractures with that. So then take the neuroma after you've cut the transverse metatarsal ligament. Take the neuroma out. I tend to take the both distal bifurcations of the neuroma, and I also go back proximally, and I put a clip, artery clip, onto the nerve proximal to the neuroma, pull the nerve as far as I can, and that's why you need to have a decent sense so you can see, and cut it at the most proximal point. And what happens is the nerve has been pulled. When I cut it, it gets retracted and goes into the muscle bellies, and it goes into the plantar muscles. And then even if it has to develop a neuroma, what it would do is it would grow into that muscle rather than trying to cause a painful neuroma. So this is a good trick. So over here is that you expose the intermetatarsal data neuroma and the dorsal nerves. If you can see, they're very clearly seen. You can see the nerves, and then you take them out, make sure that you take them out, and also consent the patient that, look, you'd be left with numbness for the rest of your life. And if you give them a diagnostic injection, then they would know how would it feel like. And it's important because we'll come to a recent systematic analysis why this is important. And this is just put a lemma spreader taking the nerves out, and this is the neuroma taken out. And it's a good trick that if you use periostal elevator, you can make the nerve dissect easier in that interspace. So here's a neuroma which has been taken out. And you would wonder what's the other one, but that was diagnosed as a neuroma. Well, the one at the top is the typical neuroma you would come across. And if you can see here, you can see that somebody has put a retractor or artery forceps and they pulled onto it, but they haven't managed to get enough nerve with it. So this is probably a good example that you get nerve on the other sides. And then obviously close the incision so that one can have a normal incision. A good scar. So the complication surgery is that, like the picture I showed you, may do an incomplete resection, which would lead to recurrence, and it might make us a neuroma, stum neuroma. So that's why if you pull the nerve proximally and then cut it, then it would retract into the muscle. People can develop painful hypertrophic scars, especially on the plantar approach. They have a potential to develop RSD, and I tend to give my patient 1000 milligram of vitamin C, 500 in the morning, 500 milligrams in the evening to prevent this. And up to 39% of people end up having resection of a digital artery. And this has been studied in about good 600-700 patients, where Sue and colleague looked at the histology specimens sent to the lab, and they found that up to 39% of the patient had the digital artery along with the nerve sent to them, meaning that it has resection done. But because of the dual supply to the toes, none of them had any major disaster. And finally, you can have a hematoma develop as a result of the Morton's neuromaxion, because the other thing which you would find, which is shiny in that space, fibroosseous tunnel, would be the third lumbrical muscle. So you need to be really careful that if it looks too shiny, then that's probably the tendon. That's not the nerve, because the nerve tends to be yellowish and slightly duller and not as shiny as the tendon. So do not cut that. If you do that, then you'd end up having a hematoma. And now this is a good example of neuroma excision. If you can see that there are two distal branches which you have cut, you don't have to go mad and cut them too distally. And there's the proximal one where you have stretched it and then cut it. And this is the example of a hyperkeratic scar on the plantar aspect. Now, I don't do it because you have replaced the pain on the plantar aspect of the foot with one problem, which was a neuroma, now a problem which is a hypertrophic scar. So that's why I always go from the dorsal side as shown before. And now this was the thing I was referring to earlier on, that look, this was a systematic analysis, again, hot off the press, which shows that all the procedures, whether neurectomy, which is you do the motor neuromaxion, neurolysis, you just go and release the transverse metatarsal ligament like carpal tunnel and leave the nerve, or injection. They have got similar incidences of complete pain relief and complete patient satisfaction, but surgery is far better than injection. Let's dive into it a bit more detail. So if we look over here, it's quite clear that I've put it up into two different colors for ease. So complete pain relief after injection is 43%, while with the neurolysis, people get pain relief 68%, while with neurectomy, i.e. motor neuromaxion, they get relief of 74%. So yeah, when you quote patients 80% success rate, we are not very far off from 74. So that's good. So if we look at this evidence, it says injection, yes, they work half the time. Then it's better to do neurolysis and then motor neuromaxion. But this is interesting. If you look at the complete satisfaction after injection, it's 35%, so not much different from 43. But the satisfaction after neurolysis was 63%, more or less similar, like 68% before. But the satisfaction after a Morton's Neuroma Axion is much less, 57%. So this doesn't make sense. The pain is gone, 74% of people are happy the pain is gone. But when you ask them, are you satisfied? Only half says they are satisfied. And the reason being because they are left with the permanent numbness, which they do not like after surgery. So it's very important that you give them, either if you're doing a steroid injection with a local anesthetic, or you give them a local anesthetic and tell them that's what you would be like for the rest of your life. Would you be happy when we take the nerve out? And then you can have a informed discussion and decision whether you need to do neurolysis or neurectomy. And I think you can always do neurectomy after if the neurolysis has failed. Now, going on to touching on to the surgical anatomy, we have already discussed where the nerve is below the transverse metatarsal ligament and divides into data branches. It's closer to the plantar side, so it would make sense that you go and cut it from the plantar side. You don't have to dig down. But because of the hypertrophic scar, most surgeons like to do it from the dorsal side. And the fibroosseous tunnel, it has got the third plantar distal artery and vein. And as we said, the shiny other structure is the third lumbrical muscle. And if you cut it, or the tendon, you cut it, then you would end up having hammer-toe deformity, which you don't want. So pre-warn the patient that, look, there's a chance you can develop hammer-toe after surgery or for Morton's Neuroma Axion. So some pearls, and we'll look at some pitfalls, and then we'll talk about some controversies. So postoperative pearls is the dorsal approach is preferred because of the early weight bearing, faster healing, and less chances of problem with the hypertrophic scarring. Distraction of the web space is easier with the laminar spreader. And only remove the things which you need to remove. And avoid removing any fat, because if it's sitting there, leave it there. Don't be tempted. Avoid removing any lumbricals and avoid removing distal arteries, but about 40% people would end up having their distal arteries taken. But if you spend time, don't make it a 10-minute operation, do it diligently, then you would only take the neuroma. So here's just telling you again that, look, it's very important that the scissors are put deep into the transverse ligament, and then I cut with the blade on top of it while protecting the nerve. And here you can see the neuroma very well. Now, another thing is that would you do second and third space? I would not do the adjoining space Morton's neuroma, for the very reason that there's a 40% chance that you can take the blood vessel out. And if you've taken the blood vessel out on the adjacent sides of the two neuromas, then you would end up going to have a toe amputation because the blood supply would be gone. So it's never a good idea. I would always address them sequentially, but never simultaneously. Even if the patient says, I would say, choose the one which is more painful or choose the one which is bigger, and we'll do that. And we have already discussed that we should pull the nerve and cut the stump proximally as far as we can to avoid presence of a stump neuroma. Now, controversies are that whether transverse metatarsal ligament alone, i.e. the neurolysis, is good enough or not. This has been around since 1970s, but it hasn't hit the mainstream yet, and only few people do it. I sometimes tend to do it from time to time, but obviously with discussion with the patient. And the evidence suggests that alcohol injections, though they are liked by people who do them, but again, they do not have a permanent resolution of symptoms, like there's no permanent resolution of symptoms with corticosteroids. Although some corticosteroid people would get permanent resolution of symptoms, but about 70% may continue to have some symptoms after first injection. So again, I think I'm hammering the point that the plantar incision can lead to painful plantar scar. There's a risk of vascular compromise and necrosis of third toe with the dual web space neuroma exchange. So don't do it. It's not worth having the stress and hassle of somebody losing their toe for a simple reason that might be an albatross around your neck. And excision of the plantar fat pad may cause metatarsal overload. So I never leave any fat out of the foot. I just leave it. It's supposed to be there, need to put it there, so leave it there. and not to confuse symptoms of the second and third metatarsophalangeal joint with the plantar plate tear or metatarsalgia or some other pathology. So thank you, everyone, and I'll look forward to meeting you guys. Perhaps you'd be either coming to Glasgow or Edinburgh to the college. Have a nice day.
Thank you, Turab, for that brilliant talk of yours. A couple of questions from our side.
Yeah.
Turab, you mentioned everything in detail, pearls and pitfalls, everything. But just one thing we want to clarify is when you resect the neuroma, you need to, should we give traction? For example, when we do an amputation, we give traction to the nerve, right? So the proximal stem migrates proximally and doesn't produce a stem neuroma.
That's exactly what I was trying to hammer the point, that I put an artery forceps on it proximal to the neuroma, stretch the nerve, and then cut it as far proximal as I can see the nerve. And then when the nerve is cut, the nerve goes backwards, and then if it has to grow, it grows into the plantar muscle. So it's very important that you do it to avoid a stump neuroma, and that's exactly what I was trying to say several times, but I think I didn't make my message clear.
Maybe the word traction was missing.
Right. Okay. Yeah.
Because that is something that the orthopedic surgeons are fond of, right? Traction.
Traction. Yeah. No, probably I should use traction. Yeah.
Okay. And the other thing, exactly, was you mentioned again about transverse intermetatarsal ligament and just a release. And when you release it, do you think it should be reapproximated back because of a potential of an instability, intermetatarsal instability?
Yeah, there is a potential for intermetatarsal instability. I agree with this, but we should not do it if we are just doing the neurolysis, because then you're defeating the object. But if we are doing the excision, then yes, you can do it because you have to cut it. And I am working on a concept where I'm thinking that one should do a kind of a Z kind of thing, so that you've done a Z, you've opened it up, and then although the Z is not, you're not trying to bring it back to the same tension, but if you just put one suture into it, a holding suture, the body would make a scar tissue and it would heal, may heal slightly stretched, but it won't go completely stretched.
Exactly. So it allows for some space as well inside.
Some space, yeah.
Okay. Just one last question before we wind up the session. What is your personal algorithm? For example, you mentioned an algorithm that was from the textbook. Is it one is patient education, the other regarding footwear, metatarsal pad, injection, or neurectomy? How do you really address a particular problem?
Yeah, so this is slightly, my answer may be slightly unfair because I'm in the process of developing a Scottish new service. And the idea is, okay, I'll tell you the service in a second. So what I do at the moment is that the patient comes to me and they would have seen a podiatrist before coming to me, because on the NHS, in a private, they would come to me directly and I would first send them off to have a metatarsal dome or metatarsal bar, and also organize a scan after examining them. And then when they come back, if the scan, when I send them for ultrasound scan, I write to the ultrasonologist, if you're happy, and especially with the COVID time period, we have to counsel them about the risk of COVID and everything with steroid injection. If you're happy, can you please inject in the same sitting if you find the neuroma? So they get injected and then they come to me after ultrasound scan. I say, look, I'll see you in 2 months' time and see how things are going and keep using the pad. So if they come back, I always ask them to keep a pain diary, VAS score, visual analog score. When they come back, they say, look, symptoms have come back. Some come back after a year or something. I say, let's try another injection. So always give them a second injection before listing them for surgery. And after second injection, if they disappear, that's fine. If they come back, then I have a discussion with them about whether they want to have neurolysis or whether they want to have neurectomy. And I tell them the thing is that once I cut your nerve, if you want to come back and say, look, doctor, I cannot feel my feet, or when I walk bare feet, if you have a piece of glass or something, particularly out there, you won't be able to feel it if it touches your toe. So you decide. But with neurolysis, the risk is 20% chance that I may have to go back at a later date if I do not get your symptoms better. So the new plan which I'm working at is that when the patient comes into the clinic, we're trying to get an ultrasound machine. So I'll get the ultrasound done there and then. We'll give the injection there and then, and we'll have the ortho test next door who would give them a metatarsal dome, and we'll do one-stop clinic and we'll say goodbye, go away. If your symptoms come back, please come back. So, but that's I'm waiting for funding for Scottish government and other things. So that's the thing in process.
Thank you, Turab. That was very concise. Turab, I think that's all the questions that we have for this session. Fantastic lecture, and I'm sure this is going to benefit a lot of people all over the world. Thank you so much for joining.
Thank you, Gopalan, for giving me the opportunity. It's my pleasure.